There's one. So our first presenter today is Christina Ralph Neerman, University of Louisville, Psychological and Brain Sciences. Fairly new to the University of Louisville in the last year. And great, I'm glad you popped up because once you shared your screen, my little side screen here with the titles just disappeared on me.
Oh
But
no.
we're just speaking about personalized networks and sensor technology algorithms of eating disorder symptoms, predicting eating disorder outcomes. And appreciate you being with us today.
Thank you so much. Yes, so I'm going to be sharing about an R15 study that we're doing right now. And we're just starting into our second year on this study. So we're still collecting data, but I wanted to share about the study. So the problem is very grave. Eating disorders takes a life every 52 minutes, which is very surprising for many people to hear. And treatments are only effective for about half of adults. And then within those half that it works for, about half of those individuals relapse with an eating disorder within about a year of treatment. And usually that is within 2 months. So there's a real need for effective treatments. And part of the problem is that our psychotherapies are based on the averages. So it's kind of a one size fits all. So someone with anorexia nervosa might get the same treatment as someone else with anorexia nervosa, for instance, but they might have very different things that are driving their eating disorder. And like this says, they're very heterogeneous. So two people with the same diagnosis could have a very, very different aspect that's driving their illness. So the unmet needs is that there is a need for personalized evidence-based treatments that can bring people to full remission. And there's also a need for clinicians who have difficulty accurately predicting prognosis because they might have someone with the same diagnosis, but they might not know exactly where they should start. And there's a need for empirical guidance to develop targeted treatments that plans to promote recovery. So the gold standard is cognitive behavioral therapy enhanced. And so that's here. So this is basically the thought that thoughts and behaviors and emotions and even the physiology of someone are all interconnected. And if they're able to disrupt those pathways between, for instance, thoughts and behaviors. So for someone with an eating disorder, it might be they have eating concerns, shape concerns, weight concerns, that then you can kind of drive someone into remission. And also there's a core belief or a kind of a central symptom, we call it, that is central to all of these things. So if you can intervene on that core belief, that central symptom, then you might be able to help someone heal. So let me just do this. Okay, so network analysis is a data-driven way to kind of get to those central symptoms and see how the different symptoms in the network are relating together. And so for someone with an eating disorder, their thoughts might be, for instance, this food will make me fat. And that could lead to restricting from eating the food because they don't want to become fat. And then from there, they might initially feel better because they're restricting, but then anxiety might set in. And then their increased heart rate might happen. And all of that could be driven from this core symptom of fear of weight gain. So the core and central symptom of this would be fear of weight gain. And the illness pathways would be all of those green lines between the different aspects. So like I said before, someone with anorexia nervosa and someone else with anorexia nervosa, for instance, may have very different things that drive their illness. So this is one person whose central symptom that's driving their illness is the desire to be thin. And then this is another person with the same diagnosis, but they have a very different network. And what's great about network analysis is that we can look at the individual networks instead of just kind of that everyone does this, so everyone will do this. So this right here is restriction that's driving their illness. And so the thought is that if we can then intervene to the desire to be thin for the person on the left and restriction for the person on the right, we can actually help them move into remission. So our current study's main questions are: which individual core symptoms and illness pathways maintain eating disorders and predict onset of eating disorder behaviors? How do core maintaining symptoms differ across individuals? And how do physiological symptoms interact with cognitive, behavioral, and affective symptoms to predict outcomes? And we hypothesize that overvaluation of weight and shape will be identified as that core central symptom, according to CBTE, and that symptoms identified as those most central symptoms will predict eating disorder outcomes at follow-ups. And then the high variability in certain core symptoms and illness pathways will vary across individuals. And that other pathways will also be invariant. So pathways between binge eating and purging, for example. So we are testing 120 adults with eating disorder diagnosis of anorexia nervosa, which is diagnosed by having an underweight BMI, fear of weight gain or becoming fat, and a disturbance in how they view their body and shape. Atypical anorexia nervosa, which has all of the criteria as anorexia nervosa, except they are not underweight. And bulimia nervosa, where they are out of control eating, and they also have compensatory like vomiting or over exercise, using laxatives at least once a week for at least 3 months. And then self-evaluation dually influenced by body shape and weight. And then our exclusion criteria is active suicidal intent, active psychosis, active mania, inability to read or write English, and medical instability. And this is where we're recruiting from, which is all remote and open across the US. So our methods and procedure, first we do a phone screening, and then we have people that are eligible fill out a self-report baseline measure. They then get a sensor band to wear for 30 days, as well as mobile app questionnaires sent to their phone 4 times a day for those 30 days. And then that's followed by a 1-month follow-up and a 6-month follow-up. And we're actually now going out to a year. So with the phone screenings, we screen for their eating disorder diagnosis with the SCID-5, the EDDI. We also make sure that they don't have any of the exclusion criteria with the mini, and we look at their treatment interview. And then they do baseline measures to test for their eating disorder behaviors and thoughts and symptoms, and their BMI and their weight suppression and medical status. And then they answer from 0 to 100 how they're feeling at the moment that they get pinged 4 times a day. And so we're able to measure their cognitions and behaviors and affect, as well as wearing sensor band technology for 30 days. So we get to measure their EDA, so their electrodermal activity, their temperature, their acceleration, their heart rate variability, and we can do that in real time. And then we're able to record the 10 minutes prior to them completing the mobile app assessments, and we can compare that to their baseline. And then the 1 month and 6 month follow-ups are similar to their screening. And so the steps for testing their hypotheses were doing a computation of both longitudinal group networks. So we're looking at the averages as well as individual networks. So we can look at the individual. And then we're identifying central symptoms and unique bridges among symptoms in each network. And then we're using those most central symptoms in regression models with their eating disorder outcomes, as well as their variability between the associated symptoms and their eating disorder outcomes. So in conclusion, our ultimate goals are creating personalized algorithms for precision treatments, and then also developing sensor technology that can predict eating disorder behaviors and outcomes. This way, we're able to intervene in someone's real life in the moment before they have eating disorder behaviors. And I want to thank our team. We have a great team, and we also have sensor band teams, and it's just been a wonderful, wonderful time. So thank you. Oh, I think you're muted, Bruce.
Say, we're doing okay on time, so we have time for a couple of questions. If anybody has any at this point.
I have a question, Christina. First of all, thank you. This was very interesting. I have a kind of two-part question. Are you hypothesizing differences between those three diagnoses? So bulimia, I guess strict anorexia criteria versus atypical. And then are you having any difficulty, I'm wondering, with recruitment of a more strict diagnosis, anorexia nervosa?
Those are great questions. So, no, we're looking at this transdiagnostically, but those are the types of eating disorder criteria that we are including in our study. So transdiagnostically, that looks at each of the eating disorders are unique eating disorders, but they might be driven by similar aspects. So that's how we're approaching that. And we've had a really great recruitment across the board. And actually, I think that we have quite a bit more anorexia nervosa folks than other diagnoses. So yeah, it's great.
Thank you.
Thank you.
I mean, not much time left, but do you have any preliminary data at this point that looks promising?
Yeah, so we're building our algorithms and kind of trying to test the sweet spot, like how little of information do we need in order to answer these questions. So I don't have data that I can share with you at this point, but next time, definitely.
Great. All righty. Well, thank you very much.
Thank you.
If you'll stop sharing, I'll be able to see what the next talk is. Okay, so our next speaker is Jenny Teeters from Western Kentucky University Psychological Science, and she'll talk about, did it to me again, yeah, click that one, an evaluation of an interactive text message-based brief intervention to reduce substance impaired driving among college students. Thank you, Jenny.
You're welcome. Is everyone seeing my slide and can hear me okay?
Yep.
Oh, great. Yeah, so I'm very excited to talk to you all about my KBRN funded randomized pilot trial, which was an evaluation of a mobile phone-based brief intervention specifically aimed at reducing substance impaired driving among college students. So as a little bit of background, substance impaired driving is a national public health concern, but particularly in the age group of 18 to 29, which we often call emerging adults. So if you look at the rates of alcohol impaired driving in the past year by age, you'll see that the rates are highest among those aged 21 through 29. And college students are actually significantly more likely to report alcohol impaired driving than their same aged non-college peers. We see a similar pattern when we look at drug impaired driving. And one thing to note is that although this includes all drugs, the most commonly detected drug found in the system of impaired drivers is cannabis. So a lot of this data is actually reflecting cannabis use. Unfortunately, traffic accidents are the #1 cause of death in this age group, and a third of all fatal car accidents involve alcohol, and 16% of motor vehicle crashes involve someone under the influence of another drug. So my KBRN pilot trial seeks to try to reduce these very risky behaviors in this age group by using a brief intervention. So brief interventions, sometimes called brief motivational interventions, have demonstrated efficacy in reducing overall drinking and cannabis use across many trials. They're typically delivered in person by a clinician in 1 to 2 50-minute sessions. They usually include personalized feedback, which is created based on a person's answers to questionnaires. And this differs from study to study, but typically includes normative feedback. So that's giving them information compared to their peers, such as you drink or you use more than specific number percentile of your peers. Feedback on risks and consequences that the person endorsed, and then also personalized harm reduction strategies. Importantly, these are delivered in motivational interviewing style. So for those of you not familiar with MI, it's a very non-confrontational therapeutic approach, which is especially important with this age group. So if you all have ever tried to convince a teenager or a college student that they shouldn't do something and tell them all the reasons why they shouldn't, a lot of times that backfires. And so we want to use an approach that actually gets them to come up with their own reasons for wanting to change a risky behavior. So with MI, we do this through open-ended questions, reflections of what the person is saying, affirmations, and then summary statements. So although these interventions have demonstrated efficacy in a number of trials, there are still quite a few issues with actually disseminating these types of interventions. So as far as accessibility, they really have not been highly accessible to most. So for example, a WKU student or someone in the Bowling Green community who is drinking or using cannabis heavily and driving after use would not have any way to access this type of intervention currently. So one way to increase accessibility is by using technology. So 100% of Americans in the 18 to 29 emerging adult age group own a cell phone according to Pew Research Center data. And we're always complaining about how often teenagers or young adults are on their phones. So this is something we can actually use for the good here by delivering these brief interventions through mobile phone. There's actually a lot of positives to using mobile phones to deliver brief interventions. You can reach a huge number of people at a low cost per person. The intervention would be portable, so the person would not have to come into a lab or a clinic. So it eliminates a barrier and makes it very flexible for participants or clients. And you can tailor and personalize these interventions and then also interact with your participant or clients through text messaging. So interestingly, past research has examined whether brief interventions delivered in person with a clinician are superior to brief interventions delivered completely automated through technology. And they have found larger and longer lasting effects when interventions do include human contact. So that tells us that the human interaction component is really important when delivering a brief intervention, but that also adds a lot of resource burden because it's not going to be economically feasible or practical for every university and every community center to hire and train enough people to give interventions to every single heavy substance using individual in this age group. So the K-Brain pilot trial aims to bridge this gap between fully automated and in-person clinician delivered by utilizing brief motivational interviewing text messaging, which I'll show you an example of in a bit. So the pilot trial, which we call WKU Tech, participants were eligible to enroll in the trial if they endorsed substance impaired driving at least 3 times in the past 3 months. After completing the baseline assessment, they were randomized to what I consider the main intervention, which is the middle bubble here, personalized feedback plus text messaging, or an information control, which was delivered in the same format, but contained non-personalized information on substance use and impaired driving. We also included a personalized feedback only condition to parse out the effects of the text messaging on intervention outcomes. And they completed follow-up assessments 3 and 6 months post-intervention. So there are a lot of elements to the personalized feedback. I just wanted to show you all one to give you an example of what one screen of a personalized feedback document would look like. So participants would view their entire personalized feedback document on their mobile phone. This was a real person from the study who reported driving after using marijuana 40 times in the past 3 months. So then we calculate their percentile, which is 97. So students are always really shocked by how high of a percentile they're in compared to their peers. Then after viewing the entire personalized feedback document, participants in the main intervention condition would receive 3 follow-up text messages that are open-ended questions, which is consistent with motivational interviewing style. So I'm going to walk you through a real intervention, and I've highlighted the questions that we ask all participants in this condition. I is interventionist and P is participant. So we ask everyone of the information you just viewed, what was most interesting to you? This person said, I found it interesting how low the percentage was for WKU students who use marijuana, and then said in their experience, they know a lot of people who do so their guess was way off. And then they also said they found it interesting that they feel so much less affected by using marijuana than the effects they read about in the intervention when driving. So the first part of this response is very prototypical. Most students way overestimate how many other students are using marijuana and then how many other students are driving after use. So the interventionist reflects back in my style. You were surprised by how few WKU students reported using marijuana based on your experiences, and you were surprised by the research on driving after use because you personally haven't felt that impaired. So then we usually give some kind of response about, it's very common to overestimate the number of students who use because we typically only think of our friends, people we see out. And then we move on to the next question because we do want to keep these brief. How would receiving a DWI impact your career goals? For this person, it was extremely, especially with my major, I would lose my license, certification, my dream career completely. I'm honestly embarrassed that I've taken the risk. I know it's happened to people that thought it would never happen to them. So then reflecting and making it a little bit of a deeper reflection, you've seen the consequences firsthand and would like to avoid them for yourself, especially since it would devastate your career goals. Then the next question, what's your plan for driving after substance use in the future? For this participant, what we want them to do is set a goal for how they'll reduce their risk in the future. So this person will use Uber if they need to go anywhere. They mentioned the times they have driven have been going out to drinks, to restaurants with friends. So in the future, they're going to have their friends come over to their place so they can all Uber together. If they know there's any possibility for drinking or smoking, and if the person is at home and hungry, they'll have food delivered. So they came up with their own reasons for changing the behavior and then also a goal for what they'll do in the future. So with the first wave of data from this study, we examined whether the main intervention was associated with changes in perceptions of dangerousness of driving after cannabis use, which is a key predictor of whether someone does drive after cannabis use. So here we found that the main intervention, personalized feedback plus text, increased perceptions of dangerousness of driving after cannabis use significantly more than personalized feedback only or the control condition. And then the behavioral outcomes are still under review for this study, but as a sneak peek, the personalized feedback plus text messaging intervention significantly reduced the number of times driving after cannabis use over time compared to the personalized feedback only group and then the information control group. And so keeping my fingers crossed really tightly that we're able to continue this work in the form of an R15. So we hope to improve the intervention with feedback from individual interviews that we've been conducting this semester. So we've been conducting qualitative interviews with everyone who is in the personalized feedback text condition. And it's my first time doing qualitative research and analysis. So that's definitely an area if anyone has expertise or has in the past done some applied thematic analysis, I'd be very interested in talking with you about that. We're hoping to replicate the trial with 240 participants compared to the 97 that were included in the pilot. And half of them will be non-college students. So we want to see if we can apply the same technique to college and non-college. And then we really want to look at moderators and mediators of outcomes to see for whom the intervention is most effective, and then what are the underlying mechanisms. And then thinking ahead post R15, hopefully, if we get to this point, I really want to focus on implementation and dissemination. There's been so many of these interventions that have found effectiveness or efficacy, but they've never really been widely disseminated. So that's something I'd really like to see happen with my work. And then also, I think that this method has a lot of potential to adapt to other risk behavior interventions. So I was so pleasantly surprised by how seriously people take the text messaging intervention. And it also seems like, in my personal experience, and this is an empirical question, but it seems like people are more open about disclosing information about risk behaviors through text messaging at sometimes than they are through in-person interactions, especially with a stigmatized behavior like driving after substance use. And I definitely want to thank Hebron for allowing me to do this project, which has really launched my research career here at WKU, and then the members of the Tech Lab at WKU who have been the backbone for all of this research. So I hope I left a couple of minutes, at least a minute, for questions.
Yeah, thank you, Jenny. Yeah, I think we have time for one question maybe. Any questions? So
This is Mark Barget from NKU. That was a really good talk. You probably
you.
mentioned this, but I'm sorry if I missed it. Who's actually doing the interventions? Is it just you, or how do you train the students or the interveners to do their job?
That's a great question. So for this project, I have limited it to my graduate students. So they're in a master's of science program, so they're not clinical graduate students, and we do a 20-hour motivational interviewing training. And that has seemed sufficient to be able to deliver the interventions, which I think is really important, because if you need someone who's completely trained in motivational interviewing or a therapist, it would really limit the ability to be able to disseminate this type of work. But I actually think that I also think that other peers could be taught to deliver these interventions, or even undergraduate students who had the proper training, I think could potentially.
thank you. I believe that's all the time we have for now. So thanks again, Jenny. So our next talk is from Western Kentucky University Psychological Science as well. It's Dr. Amy Brausch, and she'll be speaking about the dimensions of emotion regulation and non-suicidal self-injury and suicide in adolescence. Thanks, Amy.
Okay. Sorry, I'm trying to find my screen to share. Just a moment.
Yeah, it should be at the bottom.
I know my computer is just not finding my slides. Now it did. Okay.
Yep, looks good.
All right, perfect. All right, so I will be talking about emotion regulation in self-injury and suicide in adolescents. So this project started as a pilot study that was funded by KBRN that is now the full study funded by an R15 grant from NIMH. And I'm technically in the 4th year of this in a no-cost extension, since we did have some disruption in data collection due to COVID, because we are collecting data from adolescents in schools. And as you can imagine, we had to take a break from that for a little while. So I'm going to talk to you about some of the data we've collected so far, a lot of our baseline data, and then some of the preliminary prospective or longitudinal data that we've been able to analyze so far, even though we're still a little bit in the middle of collecting that. But I do want to define a few of these things first, in case you're not familiar with non-suicidal self-injury. It is intentional self-injury, like cutting or burning of the skin, that has no suicidal intent. So usually it's engaged in for different reasons, and I'll talk about those in just a minute. In terms of adolescents, up to about 30% of adolescents report trying self-injury at least once. So we know it's a fairly prevalent behavior. And even though there is no suicide intent while engaging in it, usually it is concerning behavior because NSSI is considered to be transdiagnostic, meaning it's not a standalone type of issue. We usually see it across many different types of psychological disorders. So you can see it in mood disorders, anxiety, trauma or PTSD. We see it in eating disorders as well. So it's spanning a wide range of emotional disorders. It's also, even though it's distinct from a suicide attempt, a very robust risk factor for suicide. So among people who engage in self-injury, we see up to a 7-fold increase of risk for future suicide attempts. And this is true for both people who engage in self-injury on a repetitive basis. So if they're engaging in it regularly or more than once, we also see this increased risk in those individuals or adolescents who only try it at least one time. So a lot of my work has focused on why and how does NSSI increase risk for suicide, again, given that they are distinct behaviors, but very much overlapping and interacting with each other. And I've been looking at the developmental trajectory of self-harm behavior in general to try to identify when it tends to develop, in terms of early adolescence or adolescence, and what those mechanisms are that influence that. And then a little bit further, how does NSSI specifically relate to suicide ideation and attempts? So a large part of this project is to look at the role of emotion dysregulation in both self-injury and suicide risk. And as I mentioned before, self-injury is engaged in for reasons other than as an intent to die. And the most common reason that's given by adolescents and adults is that they use it for emotion regulation. So they're feeling overwhelming, negative, strong emotions. And for some, this becomes a way to relieve those emotions or to express emotional pain in physical form, as some people describe. So then NSSI becomes a bit of a double trouble issue. So it's the result of poor emotion regulation, but then it also can become a maladaptive strategy for regulating if adolescents find that it's working in the short term. And there's some previous research that shows that engaging in self-injury actually can change the affective state. So people report decreases in negative affect after self-injury. Sometimes they even report increases in positive affect after self-injury, which then might lead to reinforcing that behavior and then increasing the chances that they will continue to engage in it. Now, there's a lot of research on emotion regulation in self-injury. There's not as much on emotion regulation in suicide, and the studies that we do have are a bit mixed on the results. So deficits in emotion regulation have been shown to be associated with suicide attempts in adolescents. This particular result is from our pilot study that we did with a different sample of adolescents, where we looked at some different deficits in terms of emotion regulation, experiential avoidance, so avoiding those uncomfortable emotions, and then interoceptive deficits, which are sometimes also studied in eating disorders, where it's kind of that inability to notice internal sensations, both emotion-wise and then also physical sensations. So kind of being out of touch with the body and your emotional experience. And both of those were associated with risk for future suicidal thoughts in adolescents who had also engaged in self-injury. So seeing that interactive effect already. But we really have limited knowledge about how these things are interacting and predicting suicide risk, particularly among non-clinical adolescents. So those who are not in an inpatient hospital, for example, or already engaged in treatment. And this study looks at multiple dimensions of emotion regulation. So this is a very common model that's used. It's based on the difficulties in emotion regulation scale, known as the DERS, where it measures 6 different aspects of emotion regulation deficits. So we have things like lack of emotional awareness, lack of clarity, lack of ability to control impulses when distressed, non-acceptance of emotions, or lack of access to those strategies when they are distressed. So this study did assess all of these dimensions. So the aims of this particular study were to examine the interaction between non-suicidal self-injury and emotion regulation deficits in the prediction of suicide ideation, both concurrently. So when we look at all of them at baseline, and then when we also look at the prediction of future suicide ideation at a 6-month follow-up using a sample of high school students. So our prediction was that emotion regulation would interact with NSSI, and that this relationship would be stronger when the NSSI was present, but not when it was absent. So if there was a history of it, we would expect this relationship to be stronger, again, both at baseline and then when we're predicting future ideation. So for our method, we were targeting recruitment from high school students. At baseline, we had a fantastic sample size of 695 high school students, which is actually more than we were expecting. We recruited from 3 different high schools here in South Central Kentucky. And at time 2, we did get disrupted by COVID, as I mentioned. Our goal sample size at time 2 was 375. So we were almost to 300 when we had to stop our school visits. The mean age was about 15. We were just over half were female, and 85% white, and 87% heterosexual. So we did collect data in the schools, and our participants who had parent consent, we recruited from those and brought them down to either the library or an empty classroom in small groups at both baseline and our follow-up. Most of our measures are self-report. We did have some behavioral tasks, but unfortunately they did not perform as well in our data. And so I'm just focusing on the self-report measures here. They did receive compensation, which is a pretty nice thing to recruit high school students, even though leaving class is a good incentive also. That they received $5 at baseline and then $10 at the follow-up. And we do have a screening and referral process for students so that if we identify any of their responses that indicate they have recent suicide attempt or suicide plan or very frequent suicidal thoughts, we are able to refer specific students to the school counselors or the crisis counselors who are on site on those particular days for follow-up. So self-report measures include those that get history of past and current self-injury. The suicide ideation questionnaire measures recent severity of suicidal thoughts. And then the DERS I already mentioned covers those deficits of emotion regulation. So to give you an idea of the severity of our sample and how often we're seeing self-injury and suicide thoughts and behaviors, at baseline, we see 14% reported any engagement in self-injury. And then at follow-up, about 10% reported that they had self-injured in the past 6 months. 25% reported lifetime suicide ideation. And then at the follow-up, 18% reported any suicidal thoughts in the past 6 months. And then this is a measure from the measure of suicide ideation, which has a clinical cutoff, which indicates that there are more clinically significant or serious suicidal thoughts. So about 3% scored above that at baseline. And we see more than 6.5 scoring above that clinical cutoff at follow-up, and then 6.5% reporting lifetime suicide attempts, and then 1.5% reporting suicide attempts in the past 6 months at the follow-up. Now to go through the results here. So we looked at non-suicidal self-injury as a moderator between emotion regulation and suicide ideation. And we looked at this as a moderator as both lifetime presence of NSSI and then also if they had any self-injury within the past year. So we'll go over the lifetime first. And you can see that our overall model was significant and that interaction specifically was significant. And then when we plot this out in the figure, that adolescents who had ever self-injured had a stronger relationship between emotion regulation deficits and suicide ideation, and that suicide ideation was elevated for those who have that lifetime NSSI. So that's the greenish blue line. And it was not as elevated for those who had never self-injured. Whoops, there we go. And then when we look at past year, so more recent self-injury, we see very similar pattern. Although our interaction was just barely missed significance, but again, we see very similar patterns here where it's elevated for those who have past year self-injury. So we're seeing that stronger relationship where more emotion dysregulation plus recent self-injury is equaling greater severity of suicidal thoughts. And then when we look at this prospectively, so baseline predicting future suicide ideation, I'll just put both of these up here because we did both of these. So for both lifetime and past year non-suicidal self-injury, you were seeing very similar patterns again, where the suicide ideation severity is increasing as emotion regulation deficits are increasing, but those with that lifetime or past year NSSI history are remaining very elevated on suicidal thoughts. So not as much of an interaction with emotion dysregulation, although we're still seeing it there. It's just more having that any self-injury history is very predictive of future suicidal thoughts. So we are seeing that relationship stronger when lifetime NSSI was present. In all of these cases, more dysregulation plus NSSI is equaling more suicide ideation. I know I'm getting short on time here, so I'll skip ahead a little bit. Additional evidence that these deficits are playing a role in non-suicidal self-injury and ideation, and it's initial evidence that they're interacting and potentially affecting future suicide risk. And so hopefully after this year, we have more of our sample at time 2 and are able to run these analyses again to see if our results still hold up with a larger sample. And these are acknowledgements to both WKU and KBRN for funding, and then the members of my lab.
Thank you, Amy. We may have time for one question.
Okay.
I had a question, Amy. This is a great presentation. I wondered, with your emotional regulation, are you also looking at people using NSSI for feeling something?
We have not looked at that yet, but some of my other work has looked at functions of self-injury, and that is one that comes up sometimes, is to kind of relieve numbness or relieve the feeling of being numb. And some other work I've done with college students, some of those functions, are more predictive of suicide risk. So that would be something interesting to look at here with adolescents as well.
Oh, that'd be great. Thank you.
Thank you, Amy. So Our next speaker is Dr. Rachel Tinius at Western Kentucky University in the Department of Exercise Science. And her talk is on utilizing mobile health technology to increase physical activity during and after pregnancy in rural communities. Thank you, Rachel.
All right, thank you, everybody. Can you all see my slides?
Yes.
Just making sure. Okay, so I already got the title here, so we'll just move on. All right, my mouse work, there we go. So the unmet clinical need that my work attempts to address here. So maternal morbidity and mortality rates are strikingly high in the US. And if you look at this figure over here, we're the worst amongst other developed nations. So definitely a major public health problem. And one big reason for this is due to the high rates of obesity in the United States. Obese pregnant women are 3.7 times more likely to suffer a pregnancy-related death. And in fact, 50% of all pregnancy-related deaths can be attributed back to obesity. So pretty scary statistics there. And this problem's not going away anytime soon. As post-COVID, there's twice as many states now that have critically high rates of obesity. So a major problem. And if you ask any obstetrician, what are some of the main things that you're seeing that are concerning, they're going to probably tell you things like preeclampsia or high blood pressure, gestational diabetes, or poor mental health. Those are probably 3 commonly cited reasons for seeing maternal morbidity and mortality. And this problem is even worse in Kentucky. So Kentucky specifically, if you look, the maternal mortality rate is almost double that of the rest of the country. So pretty startling there. We're a very sedentary state. There's also a lot of rural areas in Kentucky, and we know the health disparities exist amongst rural populations. So we know there's poorer health outcomes, and there's also less access to care. In particular, prenatal care is a lot harder to find in rural settings. People drive, anywhere from an hour to 90 minutes just for a prenatal appointment. So lots of problems identified. Unfortunately, I believe that there is a pretty simple and cost-effective strategy that can help mitigate a lot of these problems. And that is through physical activity. So we know it's well established that physical activity during and after pregnancy helps to reduce weight gain, lowers blood pressure, lowers insulin resistance, and also helps reduce symptoms of anxiety and depression. And those are a lot of the things I just mentioned as major problems that we see. This introduces yet another problem though. Despite all this information, only 15% of pregnant women actually meet the recommendations for activity. So we definitely need interventions that are designed to help get women active and stay active. There are plenty that exist, but a lot of them are either shown to not be effective or they're great, but they are not sustainable or accessible to the population. I know Jenny mentioned like it has to be able to be something that could be sustained and rolled out and not have a huge burden. So that's another problem that we run into with these interventions. So I'm going to cycle back to like 2 projects ago because it sets up what I'm doing really well now. So when I first got here to WKU, the first Cabron grant back in 2016, I said I had this thought and I realized that so many women around here had really misunderstood beliefs about exercise during pregnancy, a lot of bad information out there. So I thought, okay, let's get women in this community some education to start and also some access and see if that can help. So that's what we did. We had 80 women from the start. We ended up with 70. Basically, they completed baseline surveys. They were assigned to an intervention where they got access to this education, which is a little bit of it shown here, and also 6 places in town where they could work out at no cost to them. And then the other group was just basically received standard of care. And what we found, this super simple project, 42% of the intervention participants utilized the resources, so that was great. The intervention group did have a little bit less time spent sedentary. They had some increased self-efficacy. That's what these figures are showing. I won't go into detail. This isn't really the point. But this project, while I was able to publish some things and say there were some statistically significant findings, I really didn't feel like it was clinically that meaningful. Like we weren't really, I don't think, changing outcomes to a significant degree in terms of clinical significance. So I started thinking about it and listening to the feedback that I was getting, and people were saying things like, well, I didn't use the gyms because it wasn't a convenient location for me. And I was thinking about how do we really reach women? And it kind of was, to me, it's their phone. Everybody has their phone. That's like the one thing you can count on. So Doing a little deeper dive, 26% of the US target market owns a smartphone. So even women in rural areas have smartphones. We know apps are engaging, they're interactive, they utilize real life settings, and they're accessible to everybody. We also know that pregnant women, they're already using apps. They love apps. Pregnancy is the app or the medical condition with the highest number of apps. So we then took those existing apps, we did a systematic review of them, and we found that basically there's a ton of fitness apps out there, lots of them, but they don't have specific information for pregnant women. There's tons of pregnancy apps out there, but they don't contain workout information. So there's this void here that we're looking to fill. And so that's the direction that things went. So the next project was an administrative supplement. Long story short, how I ended up working with Dr. Schoenberg at UK, I'll spare the details. But basically we decided to develop this app that was missing. And so we started by identifying the needs of the women in our community. We did focus groups and interviews. This picture just kind of shows how that was broken down, mostly focus groups for pregnant women. And then for postpartum women and healthcare providers, we did a combination of focus groups and interviews, collected all kinds of information from them. Identified some key themes. So physical activity is critical for weight control. And also there is a strong need for evidence-based, trustworthy exercise information. Women really desire that. And so from these interviews and these focus groups, the main thing we pulled from this was, what features is this app going to have? How do we design an app that's made for the women who are going to use it? And so that's where these key features came from: goal and progress tracking, notifications and reminders, social support, time efficient programming. They wanted choices, they wanted videos. They wanted to know that the information was trustworthy and safe. They also wanted to be able to track symptoms and know when things are normal and when they should be contacting a healthcare provider. And they also desired things to be simple and user-friendly. And so that kind of led to the second aim of this project, was to actually develop the app. So this is Dex Wood. He's our app developer. And I put coffee here because I don't know how many times we sat and met for coffee and just tried to figure out, what are we going to do and how are we going to take these features and these ideas and put them into action. And so about a year of that, we have an app, and it's called Bumped Up, and it is has those features. And that brings me to the current project. Or I guess the second part of this project was then to do some baseline quick testing. So we did some wireframing. All this was via Zoom. Basically wireframing, we're presenting pictures of the app and asking the women to tell us what they're seeing. Make sure that it's to the correct level of technical and functional literacy. That all went great. Then we did usability testing, which is basically they use the app on their phone. We screen share, watch them use it. We ask them to complete tasks and we see if they're able to do it. And then they take some surveys as well. Some of our testing results are very favorable, that they like the app, it's user friendly. So we got through some of that baseline testing, which brings me to what I'm working on now, which is a second administrative supplement, this one geared specifically towards women's health. And so this is pilot testing a mobile app that's designed to improve activity during and after pregnancy. So we have Bumped Up, and we are basically assessing to see if it works. So we currently have 38 women in the trial. They're enrolled around 23 weeks of pregnancy. They're randomized either into what we're calling the mobile health program, which is access to the app, or they're in the control group, and the control group's actually getting that educational brochure that I showed you earlier. Following them through the pregnancy and also through 12 weeks postpartum. That's another unique piece of this, is that most pregnancy apps kind of drop the mom. You have the baby and they're like, yay, baby, download the Baby Center app. And you're kind of like, well, what about mom? So we make sure we keep mom engaged and help her transition back into being active. And the hope is that 12 weeks that she's kind of ready to go back to MyFitnessPal or whatever it is that she was doing before, and maintain and get back to being active again. So this is ongoing. We still have some participants that were waiting for delivery, and certainly those postpartum outcomes. But as of now, all data points, at least the key ones, are trending at least in the right direction. We also don't expect to see statistical significance. It wasn't designed for that. It's mostly just designed to see if there's potential efficacy and if our intervention is something that we can expand. But so far, everything, like I said, is looking good. Here's an example. We look at self-efficacy for exercise. Normally during pregnancy, this goes down, right? As someone becomes further along in their pregnancy, they might feel a little less confident in their ability to exercise. But in the intervention group, that's not dropping. They're at least able to maintain that sense of self-efficacy for exercise. And we're also collecting qualitative data from our participants. So we have, this is just a direct quote that I've included here, but people telling me that the activity tracker kept me accountable, kept me motivated, had great tips and education. After birth, the app didn't stop. Pieces of information like that help us feel like we're doing, the app's accomplishing what we want it to. So what's next? And this kind of goes along with opportunities for collaboration. We have a lot of feedback now, and we have a lot of concepts and things that we're ready to refine and do. We're just waiting for some funding to kick in so that we can execute. We also want to do a larger study. So we want to scale this up. We want to be able to say that our app is evidence-based. It has all evidence-based content, but we want to be able to say the app itself is evidence-based. So we're ready to scale up. There's an R01 pending now. Definitely need some key endorsements. It'd be nice to have the American College of Sports Medicine, American College of Obstetricians and Gynecologists endorse this. And at some point, we'd love to get it to a market where the women who need it have access to it. So that's kind of a longer term goal. But ultimately, we want to take our research expertise and work with other experts in the field to try to use mobile health technology to help moms and babies. So I will stop there. I did want to acknowledge my team down here. I have been fortunate to work with some awesome people. And then this is my newest addition. I feel like she's worth sharing too. So that's all I have, but definitely open to questions and comments.
Great, thank you, Rachel. We have time for questions. If anybody has some? Well,
Rachel, I have a question.
Sure.
So are you prescribing any kind of specific exercise for these folks? Can you give us an idea? Like I could see if you'd say, well, we're going to run a marathon. People are like, no, I'm not going to do that. We say we're going to just walk around the block. I'm just kind of curious of the kind of exercise people are engaging in.
It's a great question. So the goal is they have like this bar as soon as they open up the app to get to 150 minutes. And they can design that 150 minutes however they want. So if it's somebody who wants to, run 150 minutes one day, great, they can do that. You can log, we have tons, any exercise you can think of, we have an option to put in your own. Now there's going to be plenty of women that are like, well, that's my problem. I don't know what to do. I don't have something I love. What do I do? And for those women, we have this option to build your own workouts. So there's a section they can click on where they can basically self-select. There's upper body, lower body, core, stretching, and cardio. And they can pick 5 of those in any selections that they want. There's videos for all of them so they can see how to do them, how to modify. And they can basically design themselves a 20-minute workout, and then it'll integrate them and then say go, and they have 20 minutes to do that workout. So pretty much any type of exercise they like to do, they can integrate in, but we can design it for them if that's what they want. And there's also prenatal yoga in there too. So if somebody's like, I'm going to start gentle, it's kind of the gateway exercise for a lot of pregnant women. We also have an option for them to do some yoga in there as well and count that towards their activity goal.
Great, thanks.
Great. So Rachel, so does the app actually track their activity, or is it self-report, or monitor? And does the app monitor? Can you monitor how much time you actually spend on the app?
Yeah, so it does not, it is at this point, they're putting their own in unless they do one of ours. It'll automatically, if they do the 20-minute workout, it'll automatically put that in for them. We're hoping, one of the refinement pieces that we would like to add is integration with other fitness devices. So if they, wear a Fitbit or have one of those devices, we'd like it to integrate. And that's something that we just need more money to do, right? That's an expensive thing to tackle. It's not something that we here in our offices can just come up with the algorithm for that. So that's definitely a plan to integrate better with other things so that it can be a little more objective. But right now they're self-entering unless they do our workout programs, then it'll put it in for them.
Sounds great.
Rachel, I have a quick question. I think one of the interesting pieces I'm interested in, like interpersonal factors, and I'm wondering if you all have thought about possibly sort of incorporating some way for participants to have some sort of kind of group chat kind of function or something like that. So thinking about kind of how having a support group is going through kind of the same goals can sort of help facilitate change. I wonder if that's something you all have sort of thought about trying to maybe include at some point.
Yeah, it actually is one of the features. There is a social tab. They can create a username and they can make it public or not. They have those options if they want to. And they can talk to each other. They can, it can link them up by like what time point in pregnancy or postpartum they are. They can look at each other's workouts, so they can see like username, you know, X whoever it is did this workout today, and you can comment on it like great job, or like I'm gonna try that one, or like that one was really hard, or you know, so there are ways for them to talk. And you're totally right. When we did the focus groups, that was a big thing they said, is like they feel if they go like to the gym, they feel alone. Like everyone's looking at me, I'm different than everybody else. I can't just do the regular class. I want to be with people that are in my same boat. And so that's something that we made an active effort to do. But yeah, great idea. And that's definitely something that we're integrating into it, or have integrated into it.
Any other questions for Rachel? All righty, well, this has been a great session. Thank the speakers for any great talks, good information. Appreciate other participants for joining in today. And I think the next one has been canceled, so I'm guessing the next one will be in December, if I'm right there. But will be listed on the website. So great. Thank you, guys. Good seeing you.
Thanks, Bruce. Thanks, everybody.